Bom dia a todos. Continuando com o International Cardiology Meeting, Curitiba 2019. Meu nome é Mário Maranhão, acho que uma boa parte já me conhece. Eu vou apresentar para vocês o próximo palestrante, que é o Dr. Ganesan. Ele é cardiologista clínico e intervencionista e professor de cardiologia do All India Medical Sciences. O foco da pesquisa dele é em doenças cardiovasculares que afetam países de média e baixa renda, exatamente países em desenvolvimento como o nosso. Ele é editor-chefe de uma revista médica internacional, British Medical Journal Ásia. Ele estudou na Universidade McMaster, no Canadá, com o professor Salim Yusuf, um dos maiores nomes da cardiologia mundial, e é membro consultor honorário da Divisão de Saúde Humana da Agência Internacional de Energia Atômica e várias outras qualificações. It's my pleasure to present your lecture. Ele vai cobrir o tema Principais estudos clínicos impactando a prática atual da cardiologia mundial. Professor Karthikeyan.
Thank you, Chairperson. I really apologize that I can't speak any Portuguese. I won't even attempt. It's a great pleasure for me to be here in this beautiful city. Thank you to the Parnasian Society of Cardiology and João, who's a great friend. So what I'm going to do today is just talk about trials that I think, or we all think, changed cardiology practice in the last couple of years. In general, this topic is something like a top 10 list of trials, but I want to bring another perspective to this. You should remember that, the English saying, one swallow does not make a summer. So one trial does not or should not change practice. So what should change practice is the accumulation of evidence, not just one trial. So whenever we look at a trial, however well spun, however popular, however it's much media attention it receives, you always have to think about what preceded it, what is the accumulated evidence, how does it change that evidence, or how can we look at it in that perspective. So that's what I'm going to try and tell you today. So just before we start, I just want you to get a perspective of what I mean by putting the evidence in perspective. We need to think about what the status of evidence was prior to the publication of the trial. So if you just have a look at this set of graphs, I want you to have a look at this one. So this is the supposing you just look at the corresponding hazard ratio at the bottom. So the hazard ratio is 0.97, which means it's probably not made any difference so far. This is the evidence so far. And supposing you have a trial which showed a hazard ratio of 0.75, how do you think that impacts on the prior evidence? So the resultant would be more in the tune of, say, closer to the prior evidence rather than just one trial changing practice completely. So this is what I want you to remember when you look at any trial results. So let's start. And also, I just want to tell you that this is how I chose the trials for this. So recently published, 2018 or 2019, definitive trials, that is, they were conclusive. They did not produce inconclusive results, or they produced major improvements in outcome, or they generated new knowledge, which is important for practice, or they changed treatment paradigms. What we were doing before, that's changed to something which we should do in the future. So this is how I chose the trials. The first trial, is this the end of the road for aspirin primary prevention? So this, we look at the ASCEND trial. There were several trials here, but I think the ASCEND is the best trial that out of this lot. So 15,000 diabetics followed up for 7.5 years. So you just look at the overall plot of outcomes, the efficacy outcomes and the safety outcomes. I just want you to focus on the overall efficacy outcome, which was a 12% reduction overall, hazard ratio of 0.88. And overall safety outcome, which was, again, a 30% increase in risk of major bleeding. But I want you to also look at the absolute benefits and absolute risks. So if you look at the absolute benefit, it is close to about 1%. And if you look at the absolute risk, again, it's close to about 1%. So here's a perfect trade-off. You get 1% absolute benefit in terms of major vascular events, and you get a 1% increase in major bleeding with using aspirin for primary prevention. So what's the prior evidence regarding aspirin in this situation? So if you look at it, this is the meta-analysis of all the prior, including the antiplatelet trialist meta-analysis. You'll see that the results are almost exactly the same. So you'll see that any serious vascular event, about 12% absolute relative risk reduction, and the bleeding risk was also about 30% increase. So this is perfectly in sync with what the evidence was before, and this is the largest randomized trial in the current era, a relatively high-risk population, primary prevention. So this settles the issue. Aspirin is probably not beneficial in terms of net benefit when used for primary prevention. And also there were other trials published simultaneously which all showed consistent results. The second important trial, I think, which was published this year was the REDUCE-IT trial, which enrolled about 8,000 patients with elevated triglyceride levels, followed up for 5 years. And you must know that icosapentaethyl is a purified, highly purified form of EPA, which is seen in fish oils. So you know that there are a lot of trials in fish oils which have been published prior, and most of the evidence suggests that it does not benefit. So what this trial set out to do was they used this highly purified EPA form, and the primary endpoint was a huge composite, because obviously in a primary prevention trial the event rates are going to be very small, so they used a composite which included a whole bunch of things ranging from mortality to unstable angina. And what did the trial results show? So for the primary endpoint, there was a 25% relative risk reduction in terms of the primary endpoint in this situation. And for the secondary endpoint of cardiovascular death, MI, or stroke, again, there was a significant reduction in the outcomes. Now, what do you believe? You know that most of the trials in this area were all negative. So we need to remember what Friedrich Nietzsche said. So there are no facts really, it's only interpretations. So if you look at what the prior data is, this is the first graph that I showed you. Actually, if you look at it, all the previous EPA trials were negative, except for one, the Japanese trial. So the net hazard for all the prior evidence put together is very close to 1. It's about 0.97. But REDUCE-IT produced an HR of 0.75, which is a very big reduction when compared to all the prior evidence put together. But if you combine these two, it results in something which is closer to 1 again. And so I want you to think about it in those terms rather than just looking at the trial results. Now, supposing you were in the other camp, the trialist camp, and you thought that the prior evidence was not applicable to this situation because icosapentaethyl is a completely new compound, or it's a very highly purified form of EPA. Whatever trials were done before does not apply to it. They used a higher dose, quite similar to the one positive trial, the Japanese trial, which was jealous. So then, in that case, your prior evidence is much more uncertain. So your the blue curve represents your prior evidence, and combining it with the evidence from the trial, you get a more beneficial outcome. So it depends on what you believe. Is the trial is the prior evidence in this situation? So I think this is what is going to happen with this compound. So people who believe that it benefits are going to prescribe it. People who don't believe it's beneficial are not going to prescribe it. Remember that there were also important side effects of using EPA, which is increased AF and things like that. So we need to keep in mind these things when we decide to prescribe icosapentathide. And this is going to be a branded compound. It's going to be a proprietary compound, and it's going to be expensive, more expensive than regular EPA. And also remember that the absolute risk benefit in this case is less than 1% per year over a period of 5 years. So we need to put all this together when we decide whether this will change our practice as far as EPA is concerned. The third trial that I think is very important is the Cabana trial, which looked at routine RF ablation for atrial fibrillation and followed up patients for 4 years. Now, I think this is a very important trial because it is the COURAGE trial of electrophysiology. You know that the COURAGE trial generated a lot of interest and a lot of acrimonious discussions, and many people were completely against it and many people were for it. So this has actually done the same thing for RF and atrial fibrillation. So the primary endpoint of this trial was a composite of death, disabling stroke, serious bleeding, or cardiac arrest. So a very large composite. So first thing is to look at the intention to treat analysis, which means that patients were analyzed as randomized. So when we look at it, there's really no benefit in terms of doing RFA in these patients versus following them up with medical therapy and doing an RF if necessary. So that's how it panned out. But remember that this is the argument that's been used, that there was a lot of crossover. So many patients who were randomized to ablation did not undergo ablation, whereas a substantial number of patients who were not randomized to ablation underwent ablation. So this is something which complicates the interpretation of this trial. So what definitely changed was that RF ablation reduced the freedom from recurrence of AF. That it definitely did. But the trial was meant to look at whether it changed outcomes at all or not. So it apparently did not change outcomes if you look at intention to treat. But the trialists, of course, did other analysis when they found that the main trial results were negative. So you will see that the intention to treat analysis did not produce a significant benefit in terms of the primary outcome, whereas an analysis by treated groups, so as treated analysis, showed a significant difference. And there's something called a per protocol analysis in which patients underwent RF within a specified period as specified in the protocol. That also showed a borderline significant difference. Now, how do you interpret the results of this? So remember that this is a strategy trial. It is not an efficacy trial. It does not ask the question whether RF ablation improves outcome versus no RF ablation. It just says, is the strategy of using RF ablation as the initial step in treating patients with AF better than an initial medical therapy in patients with AF? So that is the question. The moment you look at it that way, this reflects what happens in clinical practice. Obviously, somebody who you think are not getting benefited by medical therapy would be referred for ablation, and vice versa. If somebody you think that is perfectly all right with medical therapy, you will not do ablation in these patients. So the initial strategy of RF does not appear to improve outcomes in patients with AF. That is what I would take away from this trial. But there's one more important thing that we need to look at when we talk about RF ablation in AF. There was another trial which was published in patients in a higher risk subset of patients, which was patients with AF and heart failure. Now, that was a Castle AF trial. And in that, it's a much smaller trial because the event rates are much higher in patients with AF. And they showed that it was, again, the composite of death, worsening of heart failure. So they showed that ablation significantly improved outcomes in terms of death or CV heart failure hospitalization. Now, and all-cause death was also improved. Now, how do you interpret these two? Because there was no signal for benefit with RF ablation in routine AF patients. But in patients with AF and heart failure, it seemed to improve dramatically. Now, how do you synthesize these two bits of information? Because we generally remember that whenever you have one intervention, the proportional risk reduction would be similar across all risk groups. So if there is a 20% risk reduction in a high-risk population, it will be 20% in a low-risk population. Only thing is it may not be important in a low-risk population because the baseline risk is very small. So this does not fit in with that paradigm of thinking. So how do you look at it? So I would ask you to look at it this way. There is something called the fragility of a trial. So when you have a large trial, the results are robust. They do not change with small changes in event rates between the two groups because of random chance. So if you look at trials with small number of patients, and in causal AF, there was a significant loss to follow-up. About 12.8% of the patients in RFA arm were lost to follow-up, which is unusual for a small trial. And then if you look at, so fragility index is something which is, if I were to tell you that in the treatment arm or the lower event arm, if you were to add an n number of patients to that primary outcome, the moment it ceases to be statistically significant is a fragility index of the trial. So you can imagine that if you need to add a large number of events and still the statistical significance between the two groups is maintained, then it's not a fragile trial. It's a very robust result. But if it's a small number of events, if you need to add to the treatment arm and it changes the significance, then it is a very fragile trial. So you'll see that in this, for the primary endpoint, the fragility index is 11, which meant that if you added 11 events here and the whole result changed, it became statistically insignificant. And it's even more significant for death. So it's a very small number of events could have changed it either way. So that is important to remember because there were 12.8% of patients lost to follow-up in the RF ablation arm. So if you had a fragility index which is less than that, it means that there is susceptibility for these trial results to be extremely unstable. So in that context, I would think that the causal AF trial does not really complicate our interpretation of the Cabana trial. It just means that you need a larger trial for patients with AF and HF to really change practice. The fourth trial that I would like to discuss is the use of SGLT2 inhibitors in diabetics at risk of CAD. This has really changed practice. And the last trial that was published was Declared TIMI 58, which was a non-inferiority trial. A large trial, 17,000 patients, 7,000 of them with coronary artery disease. So they used a slightly different analysis plan. They used co-primary outcomes, which one of which was MACE, the other one was CV death or hospitalization for heart failure. So there were two co-primary outcomes. The problem with using co-primary outcomes is that when you use frequentist statistics, you need to split the alpha or the p-value between the two. So you can't declare significance at the usual conventional level of 0.05. So they had to decide to declare significance at 0.023 for both the primary outcomes. Only then they would analyze the secondary outcomes. So the people were followed up for 4 years, and these are the results. You'll see that the one of the co-primary outcomes was significantly different, whereas the other one did not reach statistical significance, which was MACE. So unfortunately, what happened is, according to the instructions from the New England Journal of Medicine, they were not allowed to do any statistical analysis for the rest of the secondary outcomes. But you will notice that one of the biggest differences, it's a very large difference, was seen in terms of renal outcomes between the two groups. Now, it's against common sense to ignore all that evidence in a trial just because you decided something a priori and it's something to do with frequentist statistics. So how do you put this into context? So let's look at what the other trials were in this area. So this is a meta-analysis just published just recently. So this takes into account the other two trials which were also published, and you'll see that in patients, this is individual patient data meta-analysis, so it includes all patients and it allows you to differentiate between people who had CVD and people who did not have CVD. So it's not a trial level analysis, it's a patient level analysis. So you'll see that in patients who had prior cardiovascular disease, there is a significant difference in terms of the major CVD outcomes, and not so much in patients who did not have prior CVD. Again, similar for the heart failure outcomes. And we were very interested in the renal outcomes, you'll remember, and the renal outcomes are irrespective of whether patients had CVD or no CVD, there was a significant difference in renal outcomes. So this is something which stands the test of the prior evidence. And so I think SGLT2 inhibitors should be used in patients who have CVD or who have risk factors for CVD, if not for the cardiovascular benefits, at least for the renal benefits, which are substantial. The third thing is for, I've included this because I'm an interventional cardiologist, so we often see patients who have atrial fibrillation, but who also undergo angioplasty and stenting. So you know that angioplasty and stenting means that you need to give dual antiplatelet therapy, and patients who have AF need also to have anticoagulation to prevent strokes. So this is a very important area, and it's not been studied very well until recently. So if you give triple therapy, if you give dual antiplatelet plus an anticoagulation, the risk of bleeding is very high, although you prevent ischemic events. So this is a trial which was just published. So it is called Augustus. It's about 5,000 patients. It's a 2x2 factorial trial, which means that it tested two hypotheses within the same population. And it tested apixaban versus VKA and aspirin versus placebo. So remember that the primary outcome of all the trials, this trial and the previous trials addressing this issue, were all powered for bleeding, not for efficacy outcomes. This I want you to remember, so that when we finally discuss what this means, we'll find it significant. So this is the way, so in a 2x2 factorial trial, you'll have these 4 arms. So let's look at this one. So VKA versus apixaban. So you'll see that there's a significant difference, significantly lower bleeding risk using apixaban when compared to VKA. So what about the efficacy outcomes, which means death from an ischemic event is what they recorded? You'll see that they are more or less same for VKA and apixaban. So it seems okay. Let's look at the other one. So here, aspirin versus placebo. So here again, aspirin clearly increased the risk of bleeding. But what about the ischemic events? You'll see that there is a numerically increased rate of ischemic events in the placebo group when compared to the people who received aspirin. So this is, remember that a numerical increase does not normally mean anything, but here you should remember that these trials were all powered for only bleeding outcomes, which are much more frequent in this population than ischemic events. So this is a paradigm which people have used. I think it's pharma driven, because all the other previous trials also were testing newer anticoagulants. So if you remember the stent trials, there were stent trials which were done powered only to detect stent thrombosis, which is a very, very infrequent event. But here we are willing to ignore major ischemic events in favor of doing a smaller trial, just looking at bleeding events. And we want to just conclude that this is safe to use, and we leave the efficacy question under the blanket. So that is something which we need to remember here. So the question is it time to switch to DOACs and omit aspirin? First question, it's probably okay to, DOACs are probably safer than VKAs. That's for certain, because there is evidence from other trials as well. The AF trials where DOACs produce less bleeding, especially intracranial bleeding. So it's important to remember that DOACs are probably better. But what about aspirin? So this is another of the trials, from the redual PCI trial, which looked at dabigatran in the similar setting. Here you'll see that the ischemic events were all numerically higher with omitting aspirin. So that is something which really needs to be tested before we conclude that these two are equivalent treatments as far as ischemic events are concerned. They definitely reduce bleeding, but they probably also reduce efficacy. And it depends on how much value we put on efficacy before we decide to omit aspirin. Aspirin is now an orphan drug. Nobody makes money out of aspirin. So everybody wants to take it off the treatment armamentarium. So I think we should remember that when we look at these trials. Finally, I want to talk about TAVR for low-risk AS patients. So, you know, the TAVR has been there for high-risk patients, patients who don't undergo surgery. But 2 trials were published recently which tested the hypothesis that TAVR is non-inferior to surgical AVR in patients who are conventional risk. So these are all elderly patients. One of the trials used the SAPIEN 3 system, the other used an Evolute system. The primary outcome was death, stroke, or rehospitalization in 1 year for this trial. And they showed a significant difference when compared to surgery. And there was also a tendency towards fewer strokes in patients who underwent TAVR compared to surgery. Remember that these are elderly patients, and the previous concern with doing TAVR was that there was an increased risk of permanent pacemaker implantation. In these trials, at least in the published versions of the trials, I couldn't find the exact numbers for PPIs, but they stated that there was no significant increase in the PPI rate in these populations. So I think this is something which is going to change practice. If elderly patients who are low risk, who don't want to undergo surgery, who wants to undergo open heart surgery at 70 years of age. So I think if it produces equivalent benefits in terms of outcomes, I think it's a reasonable treatment. This is also supported by the other trial, Evolute trial, which actually used a Bayesian approach like we've been talking about, using prior evidence, and it also showed a significant risk in the rate of death or disabling stroke in patients who underwent TAVR compared to SAPR. So, in summary, what have we learned in 2018 and 2019 so far? Aspirin should not be given for primary prevention. I think that is pretty straightforward. SGLT2 inhibitors, they prevent MACE, heart failure, renal events, and particularly in diabetics with CAD. So I think SGLT2 inhibitors are part of standard care right now for patients with diabetes. A strategy of routine AF ablation does not improve outcomes compared to standard treatment in patients who have AF. Remember that this is a strategy. It does not preclude you doing ablation in patients who are on medical treatment. It does not preclude you from not doing ablation in patients who initially you decided were fit for ablation. Low-risk elderly patients with AF and their physicians also may prefer TAVR over SAVR. I think that's a given now because the hospitalization is 1 day for TAVR. Patients can go home after the next day and they are resuming normal activity, whereas you have an open heart, sternal incision, which is painful, which lasts quite a long time, and at 70 years of age, I think that's something which can be avoided. VKAs can be safely substituted by direct oral anticoagulants in patients with AF undergoing PCI, but omitting aspirin is probably premature, I think. It probably needs large trials. I don't know if they will be done because there is a lot of industry involvement here, and aspirin is an orphan drug. Prescribing high-dose EPA or eicosapentathil will depend on preferences and the cost. It depends on all of you and all your patients. If somebody can afford it, there is a small risk of increased AF, but otherwise it's probably harmless. And if you really believe in it, you'd probably give it. If you don't believe in it, you'd not give it. So that's my talk, and this is a picture from my country, and I take this opportunity to welcome you all to my country. Thank you.
Agradecemos ao Dr. Ganesan essa excelente apresentação. E eu queria fazer um comunicado. Antes de dizer que todos esses ensaios clínicos são extremamente válidos para países em desenvolvimento de média e baixa renda, como o nosso. O Dr. Ganesan vem de Delhi, New Delhi, Índia, onde a cardiologia tem uma grande experiência internacional. A outra coisa, eu gostaria de relembrá-los que às 17h30, no Teatro Positivo, vai haver a sessão inaugural com uma conferência da doutora Leslie Shaw, da Cornell University de New York, sobre a redução da mortalidade cardiovascular e o que estamos aprendendo com as altas tecnologias para ajudar nessa prevenção. E em seguida estará o ministro da Saúde, que é o Luiz Henrique Mandetta. Ele é um grande incentivador da cardiologia, está apoiando vários projetos cardiológicos, e ele também vai falar dos desafios e oportunidades do Ministério da Saúde com relação à mortalidade cardiovascular e o aumento da expectativa de vida que nós estamos hoje vivenciando. Dr. Ganesan, thank you very much for your elegant special lecture. Thank you very much.
Thank you.